Thank you very much. I really appreciate the invitation and opportunity to speak in front of everybody today. What I think is very important also to note is that I try to be very environmentally sound when it comes to everything in my life. I drive a sort of electric car hybrid, and when I give talks, I try to make sure that my talks contain at least 95% recycled material. But the problem, of course, with this topic is that you can't use a lot of recycled material because, as a nephrologist, you understand that the half-life is very important. And the half-life of this material is extremely short, right? I mean, everything changes constantly. So I thought I was totally going to beat Sunita to the punch by putting in something about EF case from Alberta. But no, he got me there too. So I'm going to, of course, my disclaimers, I'm not going to put the disclaimer side that Sunita put up, which is my usual disclaimer slide. But I always talk about the fact that I do have an opinion on assisted death. And I think it's important to note that, people will say, well, I don't really have any disclaimers on this. Well, I think we all do. I don't think it's possible to work in medicine, particularly if you do anything to do with end-of-life care, and not have an opinion on assisted death. The difference is not those who have an opinion and those who don't. The difference is those who have chosen to share their opinion with others and those who haven't. And I have a strong opinion on this. I believe for a long time that we should be legalizing assisted dying. I have not made any particular secret of that opinion. Anybody with access to a Google account will know that. And I'm just going to tell you, frankly, what I think about it and a little bit about my concerns. I am the former co-chair of the Physician Advisory Committee for Dying with Dignity. It's a totally unpaid volunteer position. And I'm still going to use physician-assisted dying, even though the updated glossary should have me using the term MAID. And if I was giving this talk in another 2 weeks, I promise you we'll have another term to be using next. God knows what this debate needs is yet another term. Someone's going to get it right and we're all going to understand. My kind of coming out party, as it were, I had a few, but the one in print that I thought was most significant was an article that a few of us published in the CMHA a couple of years ago. And I'm not going to tell you the whole saga about how this got published and all the stuff we went through. But our argument in this paper, which was published a little over 2 years ago, was simply to make the point that we had to move beyond the yes and no. That assisted dying was going to become legal in Canada in the very near future, and that we were frankly not ready for it. Our argument was that we have a lot of really important clinical decisions to be made as part of this discussion, and that we weren't even close to beginning those discussions because we were so hung up on the yes and no. And that was 2 years ago. This article was roundly attacked. I became sort of public enemy number one in the medical community. It was the #1 cited article and the #1 social media cited article in the CMHA, I think, for more than a year. Including very senior members of the Canadian medical community who wrote a letter saying that we got the cart well before the horse and that was a completely premature question to be asking. This was 2 years ago. No one likes an I told you so, and that's why nobody likes it. So I want to talk a little bit about what was actually in the decision, the Carter decision. I just decided on Section 7, life, liberty, and security of the person, which broadly speaking refers to autonomy and self-control. It did not consider Section 15, which was the other argument being made on equal protection without discrimination on the basis of disability, because the people in question, one of them had ALS, and she was going to potentially lose the ability to administer her own, take medications or use her own means to end her life. And so she would have wanted the assistance of a physician to help with that, and that person be exempt from criminal prosecution. And they never even considered that. They simply said, this is a simple question of your right to choose, and your right to more or less self-determination. So you're criminalizing both assisted suicide and voluntary euthanasia. For a competent adult, they did not define adult except to say adult, who clearly consents to the termination of life, previous and irreversible medical condition, and enduring suffering that is intolerable to the individual in the circumstances of his or her condition. In light of the fact that Sunita has already highlighted a number of points on this, I'm going to focus on the word adult, which we haven't. The issue of adult and adulthood is dealt with very differently in different provinces, and we in Ontario do not have an age of consent, which brings up the first point, which is that in the Carter decision, it just said adult. The select committee said that this should be something extended to mature minors. And now current bill C-14 limits it to people of age 18 or greater. So there's opportunity #1 for a court challenge. That will probably be court challenge #1 or #2 for somebody who is 17 years and 364 days old, arguing why they don't have the rights that they would have 1 day later. The simple fact is that we've talked a little bit about what capacity is. Capacity is decision specific. And when I assess capacity in any individual, amazingly, I've done this many, many times, and I've never actually asked how old the person is. Why is that? Because your capacity to make a decision has literally nothing to do with the number of times you've circled the sun. it actually is a lot more complicated than that. Right? Your ability to understand and appreciate the information being presented to you, the consequences of a decision or lack of a decision. So the mature minor in this context is a really important consideration. I'm not saying that this is right or wrong, but when I think about who should be eligible, and when we think about the case, the typical cases when somebody wants physician-assisted dying, and those who support it, what they think about. They think about somebody who has a tremendous amount of suffering, that they are dying in a bad way. They probably, generally speaking, and I'm not talking about the typical psychiatric patient, but 80% of these cases are actually for advanced cancer. So we're thinking about somebody with advanced cancer who's dying and experiencing a suffering that is intolerable. There is no prospect of recovery from this condition whatsoever. And this person is coming to you saying, I understand that I am going to forego a period of my life, but I'm willing to forego a period of my life, a quantity of life in the interest of quality of life. Okay? And that's the calculus. And if you feel that somebody should be able to forego quantity in the interest of quality, I don't know why that calculus is any different for a 17-year-old than it is for a 19-year-old. Now, that is not to say that I don't have concerns or that I don't feel that there should be more safeguards in place, but there is nothing inherent about age that changes this calculus, right? Fundamentally, we have people well over the age of 18 who can be completely incapable of making decisions, but certainly people younger than 18 who would be capable of making such decisions. And I think it's important to take that on, because the sort of mature minors and children is often held up as one of those horrible things that we shouldn't allow. And certainly in parts of Europe they have allowed it, and this has been incorrectly raised as an example of a slippery slope, even though it was done as an act of parliament, elected officials doing so in public. You know, as the saying goes, this was an act of democracy, not a slippery slope. But for some reason this is brought up as something really that we should be abhorring and not desiring. I have 3 small children myself. The idea of a child seeking out assisted dying is, I mean, it makes my skin crawl. I hope it makes all of your skin crawl too. But I can only think of one thing in the world worse than a child receiving an assisted death, and that's a child dying totally unnecessarily with horrible, intolerable suffering. And I feel the same way about adults. I want to talk about Bill 52 in Quebec. It's a little different than what's being discussed, and this will also be another issue that will come up. Of course, it always referred to as Bill 52, but for some time it grew up. Bill 52 is now no longer Bill 52, it's Law 2, which doesn't sound as cool, but there you go. Indication, it has to be at end of life. So right off the bat, this was passed by the legislature, so this became their law. It's a statute, and it defines at end of life. So Law 2, which is in Quebec, is the only place in the country up until February where it was legal to receive an assisted death, and their law is not carbon compliant. Right? So they're already saying it has to be at end of life. So that's charter challenge number 2, and I think very, very likely to come very, very quickly in Quebec, given the libertarian tendencies of the society. Serious and incurable illness, advanced state of irreversible decline of capability, constant and unbearable physical or physiological suffering. You have to be a resident in Quebec for 3 months. I used to live in Quebec, but I don't think I will qualify. You have to have confident written requests confirmed orally after reasonably spaced intervals, right? So intervals. Here's an issue that comes up a lot. How long do you have to wait between 2 requests? And that's a very, very important question. When it comes to terminal illness, on the one hand, because we know that people who have advanced illness will have bad days. And those so-called desire to die statements come up very frequently. Sometimes I think I would be better off dead. Or sometimes I just wish it would be over. These are known as desire to die statements. They are admitted by approaching half of people dying of terminal illness in a palliative setting. Those are generally not persistent requests. They're not requests, first of all. There's some statements that sometimes I feel like I would be better off dead. And those should not be conflated with requests to die, or to receive an assisted death. And they're also not persistent. They often come and go. So the understanding is that one of the things we want to avoid in this is we don't want people to make spurious or flippant decisions to end their life just because they're having a really crappy day. Right? You want to make sure that it's a persistent request that is lasting over some time. The arbitrary time period is 15 days. That seems to be common to many jurisdictions. And in Quebec, they originally had this but changed it to reasonably spaced intervals. What's being discussed at C14 is a similar interval, but could be short in certain situations, because you can understand there are many people for whom 2 weeks would actually represent the vast majority of their remaining life, and they might not wish to experience suffering for that period of time. And if in your judgment as a physician, that is reasonable to shorten it to a shorter interval between two requests, that you follow that. Okay. Bill C-14. Let's talk a little bit about that. So we talked about competent adult, grievous and remediable medical condition, and some new talk about my favorite word, reasonably foreseeable. So this has come up and become, I'm not entirely sure, no one's really quite clear where this all came from, who came up with these words. And I think, you know, you obviously want to give everybody the benefit of the doubt. These are reasonable people trying to do their best to come up with wording that will be consistent across the board and make sense to people. Unfortunately, reasonably foreseeable, this is not a medical term. This is a legal term. The reasonably foreseeable is a term that comes out very, very frequently in law. It is completely and utterly meaningless, I believe, to a medical person. Because, and I don't mean to be sort of flippant when I say that, right? But what is reasonably foreseeable? So, I mean, I have said more broadly, like, does anyone alive not have a reasonably foreseeable death? I mean, how could a reasonable person not foresee anything other than their death? Like, I mean, you know, what are you foreseeing? Like, I mean, you know, for eternal life is just not an option. But to be less flippant about it, like, you know, we sort of say, does anyone who has a grievous and irremediable illness, right, advanced cancer, advanced medical illness like renal failure, not have a reasonably foreseeable death, right? So and I called out the first speaker for talking about the withdrawal of dialysis as a cause of death. So does that mean that had you never withdrawn dialysis, that this person would have lived forever? This is a very important conceptual element in all of this discussion, right? That, you know, I've often heard it said, you know, in the cancer world, and sometimes we get chided, that people have pushed back on palliative care. No, we don't want to call palliative care because they'll give up, or that this will be harmful to the person, right? As if 27% of the population is dying of a bad attitude, right? As opposed to incurable illness, right? They're not dying because they gave up, they're dying because they had a terminal illness, right? And they're suffering horribly. And if they chose not to take on more chemotherapy, that's actually a fairly reasonable medical decision, or maybe because it just wasn't working. So again, when we talk, I mean, I don't mean to say that dialysis is the same way, but I guess it speaks to the purpose of what dialysis is actually there to do. Is the purpose of dialysis to keep the heart beating? Because if that's all the dialysis is there to, then yes, I agree with you, that the cause of death was the withdrawal of dialysis. If the purpose of dialysis is to keep the person alive in a quality of life that they value and want to prolong, then there's a point at which dialysis is no longer benefiting this person, and this person is dying of their renal disease. They're not dying of dialysis withdrawal. Anyway, I'll leave that for you. That's a deep philosophical thought, and I'd love for somebody to challenge me on that in the question period. Please do. But the concern about a term like reasonably foreseeable, does everyone have the same judgment? Like, is my foresight the same as yours? Right? So if I say, well, this person, you know, Mr. X here clearly has a reasonably foreseeable death, and I provide them with assisted death, and then it goes to the review committee, and then there's 3 people sitting there retrospectively, oh, James, what were you thinking? Like, really? You thought this person had a reasonably foreseeable death? No way, this person did not have a reasonably foreseeable death. You committed a crime. And I was doing my best. I honestly thought, in my judgment, this person had a reasonably foreseeable death, and these other people don't. So the fact that 2 people might not necessarily agree on what is reasonably foreseeable could have really significant professional, legal, criminal consequences to any one of us, right? And the question becomes then, is this, like, maybe, like, I could reasonably argue back, well, you know, maybe I just have more foresight than you. You know, I think that's not an unreasonable thing to say. I think it's fairly clear that this provision is meant to some degree to limit this towards an end-of-life moment, right, for somebody who's terminally ill. And that is manifestly contrary to the Carter decision itself. If you don't agree, if you don't believe me, we're going to look at the wording. You don't have to take my word for it. We can listen to actual appeals court judges who have said exactly those words not less than a week ago. Do we want to limit physician-assisted dying to situations where the person is already dying, right? So that's the question. I mean, their idea is that, like, we want to duck the awkward situations, the psychiatric conditions, the chronic illnesses, where people think they're going to be foregoing decades of life, by putting in this reasonably foreseeable. That's kind of a code word for, well, we have to kind of be dying kind of sort of anyway, right? And the problem is, I kind of get, I think I understand what the people who put these wording in were trying to achieve. Unfortunately, what it's going to do to us is potentially very bad. It's going to put us in a very awkward situation. Not a problem. So the Alberta Court of Appeal for case EF, severe pain, blindness, unable to walk, something called conversion disorder. So the Attorney General of Canada actually challenged it. The first time they did this in the entire country, they challenged an application for permission for assisted death. And they were overturned in the Alberta Superior Court, and they were overturned in the Appeals Court. 3-0. Carter decision was not limited to terminal illness. The exact words of the 3 Superior Court, Appeals Court judges, the decision itself was clear. No words have been suggested otherwise. If the court had wanted it to be thus, they would have said so clearly and unequivocally. They did not. This, you cannot imagine a more pointed rebuke to the federal government and the wording of C-14 than these words. Okay, and remember, all these people are auditioning for the role of Supreme Court judge, right? Like they all want to get up there, right? And so, if this is what they're writing, I mean, what do you think the Supreme Court is going to do with Bill C-14? I think that this is really important to reflect upon, because simply trying to put wording in to develop a majority or build a consensus in the legislature, knowing full well that this bill will be a dead letter, or you're more or less relying on the Supreme Court to strike down those provisions. You say, well, we'll just put all this in there. We don't really care, but we're just going to put it in there so that we get the moderates on side, knowing full well that the Supreme Court will bail us out. I think runs flatly contrary to the spirit of our Constitution, who we are as Canadians. Right? People always decry this legislating from the bench, the idea that these court judges are the ones writing our laws now. Well, to some degree, you know, if Parliament wants the judges to stop doing their job, maybe Parliament should do their job. You know, it's actually their job to write a law that will be compliant with the courts, and not something that they know will be a dead letter. I think that's a real problem. So final question, the indications for physician-assisted dying, that's obviously always going to be a professional situation. And you've highlighted some of the real problems of dealing with this in the sphere of mental illness. How specifically to improve palliative care? We can talk about that towards the end. Managing the oversight of the safeguards currently, I mean, we are, what, 2 weeks away? Have you heard about an oversight committee? Do you know where you're supposed to send the paperwork when you do this? I haven't heard. Probably something you should be hearing a little bit about now. Just say that out loud. We haven't heard anything. And no province has actually set this up in a way, except for Quebec, for where the paperwork is supposed to be sent. And that's a real problem. We had a year to work on this, plus 4 months, we've done nothing. How do we train physicians in allied health to perform physician-assisted dying? CMA has taken a really strong leadership role on this. They will have a workshop and training modules in place. Unfortunately, they won't be in place before the fall, but better than nothing. And they've done a really, really good job on this. Kudos to CMA. How do we balance the right of access with the right of conscientious objection? We're going to move on to that. So I think it's an adage in palliative care. We talk about what is intolerable suffering. We say that suffering is whatever the patient says it is. And to some degree, that's true of any situation. Whether you're talking about psychiatric illness, physical illness, I don't have a blood test or an ECG for suffering. I always have to rely on what this person is telling me, right? So to some degree, it's an easy question, because if this person tells me it's intolerable, I have to believe it, because frankly, I have no proof otherwise. But the issue, of course, becomes what is truly intolerable, or what is irremediable, what is, you know. So if somebody's coming to me because they say, well, I've got back pain. You know, my back pain is just awful, doctor, and I want you to end my life. And I say, okay, well, let's see your medication. No, I'm not on any medication. I say, well, haven't you tried some opioids? But they'd say, well, doc, I don't want to take opioids because I don't like the way it makes me feel. You know, it's going to cloud my mind, and I'm going to become an addict, and I don't want that. And I'm going to say, well, look, okay, is that reasonable? I mean, you're asking me for a massive overdose of a sedative analgesic. Can we start with a dose of an analgesic and just see how that does? I mean, I don't think that's an unreasonable request on my part as a professional to sort of suggest, look, I think there are some minimum standards for treatments that you must have tried before I'm going to call you intolerable or irremediable illness, grievous irremediable illness, or intolerable suffering. But now, how far do we push that, of course, becomes the question. So somebody else will say, well, you're saying you've got an irremediable depression, but you haven't tried ECT. Until you tried ECT, available to a whole whopping 1% of people with treatment-refractory depression, but until you tried it, I can't really say that you're irremediable. That's not an unreasonable thing to say. But clearly, I think the idea of forcing somebody to receive ECT before you declare them as being irremediable and having an irremediable illness, I think a lot of people would consider that to be unreasonable, right? Given both the questions of the significant side effects of the treatment plus the availability issues. So there's clearly a middle ground somewhere between you've got to try something to, we can't force you to try anything, and that's an issue. Also, what comes up with mental illness is the idea of different standards, right? So on the one hand, somebody with terminal cancer, I don't think many people struggle, frankly, with the idea. Like if you're in any way accepting the idea that somebody should receive an assisted death, if somebody has, frankly, end-stage cancer, they got weeks to live in severe suffering, not many people are going to stand up and say this is completely wrong on a professional level, right? And 80% of cases in Europe and in North America that receive an assisted death have terminal cancer. But when we come to somebody who's like a younger person, who appears to be physically well, but is clearly in the throes of some significant mental illness that may have lasted a long time, you know, we start to struggle with that. I mean, that's when things like 2 requests separated by 15 days starts to sound a little bit like a low bar to clear, right? Like I think these people will easily hit that. And am I going to start to be in the business of helping, you know, 275,000 Ontarians with treatment-refractory depression receive an assisted death? Yikes. You know, I've got to think that there's got to be some sort of happy middle ground here. Maybe for the quote-unquote non-terminal illnesses like mental illness, do we have to maybe set different standards or set longer delays between them? Now, of course, Sanu's brought up the really key point here about how we treat mental illness differently. Because I think it really does still step from the old stigma about mental illness. Like it's not treating it in a negative way or decrying it, but there really is a broad perception. It's just, you know, it's all in your head. It's a bad attitude. Suck it up. And you know, I can imagine what would happen if imagine if Dr. Giselle went and said to one of her patients with uremic encephalopathy, telling her to, you know, buck up, tomorrow will be a better day. You know, obviously I'm not accusing anyone of ever saying that to a depressed person, but the idea that you would treat an illness as just something less, mental illness is kind of a lesser illness, like it's not a real thing, right? And so it really shouldn't be an eligible disease that's eligible for a physician-assisted death. And I think it fundamentally boils down to the same stigma for which mental illness has always suffered, is that it's just not felt to be a real condition. It's an attitude problem, not a death. And the oversight, I think, is really important. There are different oversight mechanisms around the world. So Belgium, they have a panel of 8 physicians, 4 lawyers, and 4 palliative care practitioners who review each case. In Holland, it's a doctor, a lawyer, and an ethicist, which is like a joke. In Bill 52, and this is, I love this, 11 representatives appointed after consulting the College of Physicians, nurses, pharmacists, social workers, and marriage therapists. I'm not even touching that one. Notaries, representatives from institutions, ethics, and a patient advocate. What's interesting about this is that only 2 of the representatives will come from consultation of the College of Physicians, meaning that the vast majority of this panel are non-physicians, regulating physicians. Right? No precedence for that in Canada. 2/3 votes trigger feedback to the physician, notification to the institution or college, or in Bill 52, the Collège des Médecins for appropriate measures. Sounds dark. But if you look at literature from elsewhere, over a 4-year period of study, exactly 0 cases have been referred for remediation in Belgium, and 0.2% in Netherlands. So these are not numbers that strike me as being a very powerful oversight mechanism with a lot of feedback going on. It makes you concerned that obviously there may be some practices going on that are not being reported that might have you concerned. But again, the data does not suggest that abuses are, if anything, more common in these jurisdictions, and in fact they appear to be happening about the same frequency as they do everywhere else in the world where it's totally illegal, and are actually becoming less common. I can show you the slides if you want. In the interest of time, I can move on. Issues for psychiatry, things that I've brought up, and I think Sanu's touched on a lot of these things. Capacity, how you assess capacity in somebody with mood disorders. So inherent mental factors that limit choice should not deprive the person of access to appropriate medical treatment that may alleviate suffering, right? So again, the question of should all physician-assisted dying cases be referred to a psychiatrist? Well, I think the answer to that is no. But what about all cases of primary psychiatric disorders where physician-assisted dying is requested? I think that is definitely a reasonable request. I mean, frankly, I don't know how you could say with any degree of certainty that somebody has an irremediable psychiatric illness if you have not actually seen a psychiatrist, right? Like you probably should have seen a specialist in psychiatry to make that judgment. And of course, the question of is there something as irremediable depression and anxiety, and Sanu's already pointed this out. Some experience with depression in palliative care and physician-assisted dying. So remember that among those who requested assisted death, about half of those patients are going to have depression to some degree. A quarter in Switzerland. Review of 8 palliative care programs, though, 50% have a mental disorder, right? So don't forget that as people die and as people get close to death, This is not a higher number necessarily than you would expect to see in just a random selection of the dying population. Not unusual. Review of the first 100 patients from Belgium with a request for assistance assisted dying based solely on psychological suffering. Again, Sanu showed you these numbers. A little more than half had depression, about half had a personality disorder, some with Asperger's. Notably, this is the number you should pay attention to. 48% accepted for PAD. This is what's lost, I think, in a lot of the discussion around assisted dying, is that doctors sometimes say no. And they don't say no for moral reasons. They say, no, I don't think you meet criteria. So come back to this patient who's asking me for physician-assisted dying for back pain, but they've never tried anything to treat. Okay, fair. You don't have to accept my opioids, but I also don't have to treat you. Like I can actually say in my professional judgment, without even touching my question of conscience, I don't think you have an irremediable medical condition. I don't think you have a grievous and irremediable medical condition, and I don't think you have intolerable suffering. So that's one thing that shouldn't get lost in here, that just not every request needs to be rubber stamped, and maybe that's just the fact that we're Canadian, right? And we never say no to anybody for anything, right? You know, the joke about how do you get 100 angry drunk Canadians out of a swimming pool? You say, excuse me, everybody, the pool's closed. Right? Canadians are like world leaders in going with the flow, so when we get a request, we're sort of naturally, we try to be sort of ingratiate ourselves to patients, and we're sort of expected that we're going to follow through and do what we're asked. And it's important to highlight that you can say no, and probably should say no in certain cases. But the key point here is that ultimately this will only account for a tiny minority of referrals and actual cases where physician-assisted death is providing. I'm going to quote my previous speaker, which is a very cheeky review. Does not recommend psychiatrists be involved in the procedure of prescribing or administering lethal doses of medication. Should be involved for cases of mental illness, but not routinely for other cases. But rarely, if ever, should mental illness be considered irremediable regarding interventions aimed at addressing psychosocial stresses for a person with mental illness. I think that's a really important point for you guys, because again, holding out terms like irremediable as a concept in psychiatric illness is a very challenging term. Much easier in terminal cancer. Very, very much complicated when you come to psychiatric illness, to call something irremediable. Maybe I'll just sort of quickly talk about conscientious objection as a big issue that I have come up against in the recent past. And because of my public position on this, I don't think it will come as a great surprise to anybody that I get a lot of emails and phone calls asking if I'd be willing to drive out to small town X to help out with their case. And actually patients calling me asking me what I'm doing next Tuesday at 4 o'clock. I don't like those calls. But conscientious objection is a real issue. And a lot of people have sort of stated, and the Supreme Court made it very clear, they said that, look, nothing in this compels any physician to act, and people have commented that the Supreme Court decision clearly created the space for conscientious objection. With great respect to the Supreme Court, we didn't need the space. We had it. Every professional society in this, and every college in this country had clear mechanisms and clear rules about conscientious objection. Not all of them were stunningly clear as they could have been, but nothing compelled people to provide, certainly nothing compelled people to provide everything that they were requested to provide. And they could object on the basis of conscience, and that was recognized. But what we don't have is the mechanism. I'm going to explain to you why that plays out badly. This is Sandy Trunter. I'm not telling you any information that is not available publicly. This is the back of my head. This is a CBC screenshot from a CBC documentary a couple of years ago. One of my other comings out in this debate. Sandy had a terminal illness. I won't go into the details. She had extremely painful lesions, masses, that were causing her a lot of pain, and she was pacemaker dependent. And she wanted to, when her painful lesions became to the point that she was experiencing severe suffering, she was essentially housebound at this point, almost bedbound. She said when she was very close, and when she got to that certain point, she wanted to have her pacemaker turned off to be allowed to die. Perfectly legal in Canada to have that done. She asked her local palliative care unit to help, and asked if she could be admitted for symptom control after and have her pacemaker turned off and be allowed to die. And they said no. They said no, they didn't agree with it, they thought it was wrong, they thought it was murder, and that it was not legal according to law, and that they wouldn't do it. In this case, what ended up happening was the CBC producer contacted me for an opinion, and when I heard about this case, I said, no, this is perfectly legal. So I actually had letters sent from legal opinions from CPSO and from the Ontario Hospital Association confirming that this was legal. The facility did not agree. They said on a moral basis they disagreed with this act and they would not participate. So this is, I'm not going to get into whether they were right or wrong. Okay, obviously you know what I think. But this became a test of Ontario's ability to handle conscientious objection in 2013. Right? Now here was somebody who was trying to get a service that was legal, but for whatever reason the facility would not provide it. And I was attending at the time in an ICU, and I could not get this woman admitted anywhere for symptom control and have her pacemaker turned off local where she lived. And in the end, I did the only thing I could, which was I admitted her to my ICU for palliative care. And I had to load her in an ambulance and drive through 2 area codes, past 9 hospitals to get to my facility to receive, to an ICU bed to receive palliative care. And this is the most densely populated, most resource-rich part of the country. And that's what we had to do. And her daughter, in order to come and watch her receiving palliative care for the remainder of her life, had to drive an hour and a half in each direction every single day. You know what traffic's like in Toronto, in order to get her care. We have no mechanism in Canada to handle conscientious objection. Okay? And anyone who says otherwise is living in a dream world, frankly. Okay? And you may be able to find other willing providers, but that doesn't mean that you have the ability to simply transfer these people to another facility where this can be provided, or where other providers are simply waiting to receive these cases. Let me ask you a question. By show of hands, imagine if you, everyone sitting in the audience, imagine you were a conscientious objector and you will not provide this, right? Just hypothetically, maybe this is true of you or not. But if you were somebody who did not provide this, and you saw a patient in front of you who met criteria, clearly met criteria, and you were willing to admit that, but you did not want to do it yourself. How many of you know the name of the person? You have had a friend or colleague tell you to your face, I will provide this for you, send those cases to me. Put your hand up. Okay, I see one half hand. Okay. Now, this I think makes the clear point about the problem with the idea that we're just going to conscientiously object and refer people to other providers, is that most of us actually have no clue how to even begin that process. And to start casting around and sending emails and phone calls. So this idea that the CPSO has put out that we have a duty to refer, well, that's all well and good. But even if we have a duty, where's our mechanism? How do we do this? And then to the dear conscientious objectors, and again, I want to strongly respect the right of individuals to conscientiously object. I have no wish to impinge upon their rights to conscientiously object. And if they say that they want to only have a duty to inform, they don't want a duty to refer, they want a duty to inform, okay, good. Well, if you don't know who you're going to call, what are you going to tell them? Like, what exactly are you going to inform them of, except your own ignorance? Because, again, with no mechanism, there's no, I think whether you have a duty to inform or a duty to refer, as I say, it's like, my analogies, it's like 2 blind men arguing over what color to paint a wall. It doesn't matter, right? Whether you just need that mechanism in place. And again, I think we really need to work very hard as a professional society and as a group of physicians, whether it's through the OMA or through the ministry, to create this mechanism of willing providers, people who can be referred, so that the pressure is taken off of the conscientious objectors, that there are multiple points of access, that the patients and family members themselves can access it, so to not put the objectors in the awkward position of being the ones to say no or have to find a provider themselves. And that's probably what we should have been doing for the past 16 months, instead of having this argument over whether we had a duty to inform or a duty to refer. That's my opinion.